Hello and welcome everyone to tonight's VMR. We are so happy to have everyone here and appreciate you all joining tonight. Tonight we have a very special VMR planned. We are doing a pulmonary case tonight. And so we have Max Diddams, who is one of my former residency colleagues and now is a pulmonary critical care fellow at UNC, who I volunteered to present a case and was kind enough to do so. And then we have Panagis, who is a faculty at Johns Hopkins University, I believe, who is going to be discussing the case. So if you all could just introduce yourselves and say something interesting about yourself, like a hobby outside of medicine, I'd appreciate that.
Who do you want to go first? Do you want me to go first? Given such a, that's what you get when you get so many altruistic human beings. It's like, well, I'm not going to go first. You can go first. So hi, everyone. My name is,
I would love you to go first.
Yes. My name is Panagis Galiatsatos, Panagis with a bit more of an American accent. As you heard, I'm a physician faculty at Johns Hopkins School of Medicine, Pulmonary Critical Care. One hobby that I have outside of medicine, I know this is going to sound cheesy, well, it's travel, but it's really like with a massive archaeological spin. I'm at home visiting like ancient temples, not so much at the beach. So that's my hobby.
Where do you like to visit these ancient temples?
So being Greek, so obviously Greece, Turkey, Cyprus, Syria, Lebanon, Jerusalem, Egypt. That Middle Eastern region has my heart. So, but I do have plans to visit other places in the near future, but that's where I tend to like to go a lot.
Awesome, that is so cool. I'm definitely hoping to make it to that part of the world at some point. Max, if you just introduce yourself, that would be great. And then we can just go ahead and get started on the case. Max, we can't hear you. And that is a very rare occurrence.
Yeah, very rare occurrence. Better now or no? All right, better. I am still Max Diddams, still from University of North Carolina, in the pulmonary critical care. I'm one of the second-year fellows. Lovely to meet you all. Outside of medicine, during this time of having a little more home time, I've started growing shiitake mushrooms and oyster mushrooms on logs and substrate, which has been really rewarding, and definitely nerding out over the cultivation of mycelium. And when I can't go outside for any of that, I've been reading. I'm trying to keep on my Chinese language skills from undergrad, which has been a lot of fun. But other than that, just a huge nerd, second only to Anne-Marie, or well, probably third and fourth to several others. But anyways, yes. Shall we get into it then?
Yeah, let's do it. I was going to see if we could get one discussant to pair up with Panagis. So would anyone be interested in discussing the case first with him? We would love that. If not, then we can just kind of do a different format and just have him discuss the case. So I'll give it a minute or two, and if I don't hear anything, then we're just going to blaze on ahead. Okay, awesome. We already have a discussant. So Vivek, would you unmute yourself and introduce yourself? And then if we could get the whiteboard up, that would be great.
Hey, so I'm Vivek. I'm a medical graduate from India, but these days I work as a research assistant at Northwestern in the neurology department. And yeah, first time discussing a case, so hopefully I don't butcher it, but we'll see.
Awesome. Well, this is all about learning. So that's the objective. So there's no butchering cases. There's only learning opportunities.
And also, Vivek, remember, it's my first time here too. So this is cool. Like you and I, we have something in common. That'll be great.
Okay.
I'll get you a Starbucks.
Thanks. That would be
Okay,
helpful.
awesome. Well, let's get the case started. I'm so excited.
All righty here. So we'll just start out chief complaints. So we have a 21-year-old female. She's got a past medical history of recently diagnosed IBD, still being kind of fully worked up. Probably it's Crohn's. And she got a dose of infliximab and some steroids. She also has a history of PE on Xarelto, and she's coming in with bloody diarrhea. I swear this is a Palm case, with shortness of breath and chest pain. The GI team is jumping on the bloody diarrhea, but they'd like your opinion on some of her shortness of breath and chest pain. Now, a little bit more about her presentation here. She says that she's never had chest pain or shortness of breath quite like this before. It seems a little bit different than when she had a pulmonary embolism. It started about 2 weeks ago, about the same time as her abdominal symptoms started getting worse. As I said, this IBD is fairly recently diagnosed, about 3 weeks ago, or 3 months ago. And she got 1 dose of infliximab at that time. And it was noted during that first diagnosis that she had an abnormal CT scan with a small nodule in her left lower lobe, and that the GI team has gotten very excited about this since they've admitted her. And incidentally, on her CT enterography when she got here, that small nodule is now a cavity. So I'll stop there.
Okay, Vivek, what are your thoughts here?
So this is an interesting one. 21 with bloody diarrhea, chest pain, and shortness of breath. The fact that she's so I believe so she's on infliximab and steroids. So there's a couple of things that I'm thinking of. One of them could be something like a PE, although that wouldn't explain the bloody diarrhea. But also I'm thinking, because she's been on steroids, I don't know if 1 month is long enough, to cause her to be significantly immunocompromised. But if it were, then we could be looking at something like, an opportunistic or, some kind of pneumonia that's specifically fungal. The abnormal CT with the lower lobe nodule, I'm not sure what to make of that, unless you want to maybe repeat a CT and see if it's stable or if it's growing. But yeah, at this point, it's a pretty broad differential. Like, can't say that I have anything specific in mind for this presentation yet. So if I would definitely ask about, associated symptoms or, any potential triggers, and then do a workup for her, see if she's febrile, tachycardic, see what her saturation's like, things like that, and just see what, if she needs any emergent management, or if we have a little time to work her up a little more. So that's where I'm at right now with this.
If I ask a few, yeah, perfect. So Max, jog my timeline memory. I know you guys are writing it up as well. So her inflammatory bowel disease diagnosed 2 years ago, 1 year ago.
So her IBD has just been diagnosed 3 months ago.
Diagnosed 3 months ago. How long have her symptoms been going on for? Do you guys know that?
So the chest pain and shortness of breath. And
I meant going back to her IBD, just her below the diaphragm. I know I'm a lung doctor. It's crazy.
Below the diaphragm.
Yeah. How long have her symptoms been going on for?
They've been going, so when she was first diagnosed 3 months ago, they had been going on for honestly a couple months. She had had kind of recurrent into chronic into frequent diarrhea, along with some weight loss that eventually became bloody. She also presented initially to an emergency department with bloody diarrhea, which led to her diagnosis and workup.
And so all the time she was having these, so it sounds like within a year, she developed symptoms ultimately leading to a diagnosis of IBD. Sounds, I would say, colonic if they aren't able to separate ulcerative colitis versus Crohn's. And probably during all the imaging, somewhere during that time, they caught a small lower lobe pulmonary nodule.
Correct, correct. This is on the CT interogram.
Got it. So before the infliximab and before the high dose steroids, they caught a pulmonary nodule at the basis. Okay.
Exactly.
Okay. And last question from my standpoint at 7:13 p.m. Eastern Standard Time. When was her PE diagnosed?
So her PE is a good question. Her PE was actually diagnosed during that initial admission. She was in the hospital still being treated and felt that she had some shortness of breath, which of course led to a reflexive CTA PE scan, and was found to have a PE and started on Xarelto at that time.
Got it. So she gets diagnosed with a PE during the time of a workup for the below diaphragm issues, and also an incidental small pulmonary nodule, which I only say this with some level of massive curiosity, because if you got an angiogram, you can tell more than just a pulmonary nodule, because if there's like a feeding artery going to it, maybe it's an AVM, maybe it's an infection, meaning the contrast allows you to kind of deduce this a little bit more thoroughly. But with that said, those are all the questions I had at the moment. Back to you, Max.
Sure. Should I keep going forward just a little more detail into her past medical history, Anne-Marie?
Yeah, kind of, is there anything, Panagis, that like kind of with these symptoms that you would be concerned about or kind of be thinking about with kind of these things? I know the questions kind of helped clarify some of the timeline, but just any initial thoughts that you had before we get more information?
Right. So from my standpoint, the gut and lung stuff always is fascinating. I mean, they have an embryological, to some extent, some of the gut has an embryological origin as the lungs do. So usually these things tend to come on pretty simultaneously, maybe some age gap here and there with regards to IBD as well as to pulmonary issues. She's really not having pulmonary issues. I mean, she had a blood clot, which in of itself, IBD patients have a massive inflammatory response. So deducing why that would occur will be fascinating, right? So like she's trying to bleed out and she's having an inappropriate clotting at the same time. I mean, something is off there. And then for a pulmonary nodule to be found, then lo and behold, you flood them with immunosuppressants and something begins to blossom. Was it an infection that just had an opportune time to grow, or did it take advantage of something from an autoimmune process to allow itself to expand? So there's a lot of differentials. I mean, infection versus autoimmune in regards to a cavitary lesion. Infliximab in of itself can cause a reflexive development of sarcoidosis, which in of itself can be cavitary provoking. The high dose steroids is concerning. So high dose steroids have caused at some point in time an immunocompromised status. Everyone can have their different opinions, like, oh, you need this long a time or that long a time and that amount of, from my standpoint, I think anything more than 20 milligrams for more than 2 weeks, you're setting yourself up. So from my standpoint, infection is probably the big one. In the back of my mind, also thinking to some extent, could this also be autoimmune? Malignancy could be a consideration. Lower lobe nodules are usually going to be metastatic versus a primary cancer. So a lower lobe finding for a metastatic cancer, like I'd be thinking like of a renal cell, for instance. But I say all this because I have to still take a step back. The IBD picture, blood clot, it's just, there's something that just doesn't sound all very, like there's more sleuthing I'd like to do there, because I think ultimately this little pulmonary nodule maybe that became a cavity could be an epiphenomenon based off all of this. or some way, shape, or form, Occam's razor is rather sharp here. But that's what's going through my mind. There's more to come, I imagine.
Absolutely, and I love the differential here. All right, so moving forward, talking a little bit more about her past medical history. Really, she didn't take any medicines beforehand. She just has this recently diagnosed IBD and pulmonary embolism. Unfortunately, kind of factoring to more of her social history, finances were a significant hardship for her, and she was not able to come back and get her second infusion of infliximab, and actually ended up basically being off of steroids from the time of her finishing her initial steroid taper to the time of presentation here. So she's been off of any immunosuppression for at least 6 weeks now, depending on how long you think the half-life of infliximab is. Additionally, just in general, she lives with her mom. She works at a gas station. She does not smoke cigarettes or use any tobacco products. She doesn't drink alcohol. She's never used any sort of recreational drugs. But talking to her a little bit more about other exposure histories, while she hasn't had any inhalation exposures, she did live with an aunt who had active pulmonary tuberculosis when she was 8 years old. And that was for at least a few weeks until her aunt got treated. They've also lived across the American Southeast and some of the Midwest, moving to and from Illinois over several years. And from a family history perspective, his only remarkable mom also says she has a spot on her lung too, but no family histories of lung disease or inflammatory bowel disease. If I didn't say it, she has been on infliximab steroids, but is just on the Xarelto right now. And should I jump into a physical exam here real quick?
Can I jump in? If this is unorthodox, Emily, tell me, or Max, be like, mute Panagis, like you're done. So I want to just make sure thoroughly. So from a pulmonary standpoint, if you ever investigate especially young patients, though I don't want to sound ageist, if you get I've asked the 90-year-olds, like, tell me about your birth history. So one way to just make sure that someone's pulmonary structure, anatomy, right off the bat is good to go, right? Is a bit more information that I would want to know in a young patient is, hey, at birth, were you born full term or did you spend any time in a neonatal ICU? Around this age group, people will know. If they're 90, they're like, I don't know, I survived. Like, I don't know what to tell you. So I'd like to know that because that in of itself can set up a patient for some level of an immunocompetent lung from genesis, right? So babies, premature babies will always have their lungs, usually from BPD or other disorders, their anatomy of their lung will always have some basis of just not being at its promised fulfillment. And so they come with some level of extra morbidity that in of themselves, they can begin to compensate as they physiologically get older and older. So one is I always like to know, hey, what's your birth history? Using those questions, born at term, did you spend any time needing oxygen, gives you a good basis of where the lungs are to begin with, right? Are they given every possibility for being, having the ability to reach maximum capacity? Then you go into childhood. Tell me about your childhood. Recurrent infections, yay or nay? Because could this pulmonary nodule just be something that's been there and for years, right? Kind of just sits there in an insidious manner, just waiting to take advantage of an opportune time. And again, if you had premature lungs and so forth, it just adds more fuel to the fire. Because in premature lungs, even though there's healthy parts that develop, there's other parts that get underdeveloped, right? There's an immunocompetent state versus an immunocompromised state because of that underdevelopment. So those are things that are going through my mind, in addition to things that you just brought up very nicely, like any inhalants, electronic cigarette usage, given the fact that all of them aren't FDA approved and you can use a variety of contaminants. I'd like to know that as well. So that's what I would also be asking, just to kind of fulfill the picture. Just to be able, from a lung doctor standpoint, I always want to know, where are my lungs starting at? Like, were they always good lungs to begin with? Right? Because I doubt she had PFTs all her life. Or are we starting from behind the scenes, and then that sets you up for a variety of more unique diseases and so forth. So recurrent childhood infections to, her birth history. Any chance, Max, that has been taken or not?
So we spoke to her about this to some extent. She did not remember, and her mom was at bedside and said she didn't have any significant problems as a baby, but she was sick with something, with a bad chest infection or something They weren't really sure, maybe when she was in her teenage years. They're not really sure exactly when it happened. It's a bit of a murky time, but she didn't have to go to the doctor, and that was about the extent of any sort of pulmonary illness she recalls from childhood, or her mom.
All right. And any electronic cigarette usage?
No, no vaping.
Okay.
Still excellent questions.
And real quickly also, Max, is there any history of an international travel or anything recently for her?
No, she's met many people, but she has not really, besides the Southwest and the Southeast and the Midwest, she has not traveled internationally.
Okay, Vivek, what are some of your thoughts here?
So, you know, I don't know if I have anything, if I have too much to add beyond what Panagis said, but given, her young age, her history of immunosuppression, even though she's not actively on immunosuppressants, it could still have led to an immunosuppressant state, where, she's more vulnerable to opportunistic infections. There has been a history of, contact with tuberculosis. So maybe it's been latent, and now, because of all this medication and her Crohn's disease, it's had the chance to flare up. So again, I guess like an infectious etiology is definitely on the top of my differential list, followed by some sort of autoimmune process that's now affecting her lungs. So I'd also, American Southeast and Midwest, I know there are certain fungal infections or certain strains of fungi that tend to be more common. I think histoplasmosis is one of them, if I'm not wrong. And so that's another thing to kind of consider for me. And yeah, beyond that, I'd be looking forward to see if the physical exam, throws up anything else of significance that can help us kind of focus our differentials in one direction or another.
Awesome. Panagis, any other thoughts or things you kind of wanted to highlight based on the information we have so far?
No, Vivek, well done, my friend, with great discussion. Wrap up there. She seems like a U.S. world, a U world question right off the bat. So you're covering all your bases, fungal and so forth. Well, I think with this last question, I'm going to probably put to rest my thinking towards the GI stuff. Max, you said IBD. Someone made a great comment. They're leaning more towards Crohn's. Bowel-wise, is it small bowel predominant or colonic predominance? And there's a reason I bring them up, just because to some extent. So let me finish there. Turn it over to you. Do you know what bowel anatomy is at play?
I do, and it's mostly involving the colon.
So just the from patients, whether it's Crohn's induced or ulcerative colitis induced, messing with a colon is just, close to 60 to 80% of your immune system is just localized there in order to keep things at bay. And so that's a massive inflammatory response that you have to mitigate through immunosuppression. So ulcerative colitis or Crohn's, either way, you're going to use heavy machinery, case of infliximab and the high dose steroids. So I think we bought her some level of an immunocompromised state. So I think we have to think in those terms as well. My I don't have another massive thing to throw at in regards to a differential. It's just, again, the fascinating part is that you have a inflammatory activity in the colon happening. She was able to mount a atypical clotting cascade where she formed a clot even though she was bleeding at the other end. And at the same time, she seems like she had a nodule that, from TB exposure to histoplasmosis from the Southwest. She's got all the U world recipes or ingredients there for a very unique case. So from my standpoint, last comment, Max, was she complaining of pulmonary complaints, or again, was this cavity like just an incidental finding at this moment?
Besides presenting with the bloody diarrhea, she actually complained of significant chest pain, tightness, and as somebody asked before, it was very pleuritic in nature.
Okay, got it. So we want to make sure, you know, what the anatomy of the lungs look like, right? Because your lungs predominantly don't have pain receptors. So chest pain, I rarely think of the lungs unless it's doing something to the pleura. So I'm curious to see what that looks like, especially because what you're not telling me is coughing. Like cavities in immunocompetent people will cause some level of coughing just because it's eroding a lot of the cough receptors in order to make a cavity. Sounds like that's not even on her radar. And I say this because it's like, oh, let me pull strings. Are you coughing? Maybe. Like cavity coughs are pretty loud, pretty obnoxious. It's one of their biggest frustrations. And usually you're hearing it as you're getting a presentation. Immunocompromised individuals tend to not have it just because of where the cavities tend to form, more pleuritic sometimes at base. So just interesting to see what her anatomy looks like as well.
May I ask a quick question? What would be your approach to a cavitary lung lesion? Like, is there anything that kind of, if you see a cavitary lung lesion, how you approach it?
Yeah, so pictures are worth 1,000 words. So what it looks like on the CAT scan would be of interest. Sometimes your differential is made just alone by the radiographic findings, like aspergillus has a pretty common one with a halo effect and so forth. The past medical history, as Max gave us, is also massively important, right? If there's any hint of immunocompromisation, well, suddenly now, you know, like almost everything could be at play here. There are inhaled products as well. It is also important to recognize, especially, I bring up vaping just because there's been a ton of fungal and mold infections brought on by that. And then finally, it's age, right? If you're in a cancer-provoking group, you know, and it's lower lobe, I'm thinking cancer high until proven otherwise. I say this also because the pulmonary nodule could still have been cancer, right? You just unleashed immunosuppression, which allowed the cancer just to grow, right? Because your immune system still keeps cancer cells at bay. So for my differential, I still go through infections and cancers predominantly. Do I think of autoimmune? It's got to be in the right context, right? So that could still be like your Wagner skin, not Wagner's, GPA, sorry, no more Nazis. GPA could be there. So I do think of it, but I'd be looking for a lot more systemic symptoms. Like I've yet to come across a vasculitic cavity that is just pulmonary alone, right? Meaning your vasculitides that cause cavities like GPA, usually the patients have a ton of systemic symptoms, and then the nodules are just caught, or the cavities are caught incidentally. So autoimmune is in the back of my mind, malignancy and infection. That's how I approach it. The CT scans do help to some extent, kind of break that thought process up a little bit more. Emily, is that helpful?
Yeah, that was really helpful. Max, would love to hear more information.
Absolutely here. So I'll give you guys a physical, so let's get some vitals. This is when she just comes in to meet you. Her blood pressure is 114/76. Her pulse is 94. Her temperature is 36.4 oral. She's breathing 16 times a minute. And her saturations on room air are 96%. In general, she looks pretty good. Scared younger woman who's in a hospital having all these problems. She's having a whole lot of other symptoms, but as far as her physical examination, her HENT is pretty normal. She doesn't seem to have any sort of sinus disease from an external inspection. Regular rate and rhythm, no murmurs. Her lungs frankly sound clear even under close auscultation, knowing the CT findings, and her work of breathing is normal. She has no peripheral rashes. Her skin is warm and well perfused. And she doesn't complain of any sort of neurologic deficits, no sensory deficits, and none can be elicited on examination. So I guess I'll pause there. And if you guys have questions on particular labs to go next, unless I should jump ahead to that.
Were there any positive abdominal findings on this presentation?
Besides the symptoms of bloody diarrhea, her abdomen was remarkably soft and non-tender.
From a dermatological inspection, any petechiae, any telangiectasias that popped up when you were investigating her?
Excellent question, and no rashes, no petechiae.
Next question. Did you go over, how did her mouth look? She had all her teeth, good dental hygiene, oral hygiene?
Great dentition, no dental work, no nodules, and no posterior pharyngeal cobblestoning.
So sorry for so many physical exam questions. High dose steroids, again, who knows how long this can take? Sometimes it's just, you can expedite chronicity if you're just with high levels for certain periods of time, but any steroid related complications that you found on her, any adiposity buildup under her occipital protuberance, any thinning of the skin anywhere?
Nothing specific that would seem out of the ordinary for an excess steroid exposure. Her weight, I think her BMI was 23, and she didn't think she had really gained or lost significant weight since her initial diagnosis, though she had lost weight prior to the initial diagnosis, and no stretch marks, again, no buildup in a sort of centripetal fat or more central weight gain.
Got it. And those are all my questions right now. I will yield my
Would you kind of share the thought process of why you asked those specific questions, what the things you're looking for are?
Yeah, so inflammatory bowel disease, right, is, we will dub it as an autoimmune phenomenon. Some people just call it more of an auto-inflammatory phenomenon, because usually you're overreacting, not to your cells, but usually to some colonized bacteria. That's fine. But in the colonic area, it's a massive inflammatory response that can create kind of a disharmony with other parts of the inflammatory response that you sometimes keep in check. This is where I'm like still fixated on, forming a blood clot is common in IBD just during the massive, dysynchronous, right? You're bleeding on one end and you're trying to form a clot. It'd be like the equivalent of like if you shaved, nicked yourself, and then you formed a PE because you couldn't form a really harmonized blood clot on your face. That can happen, right? You see that level of dysynchrony. To me, that usually reveals it's a very significant disease. So the reason why I'm bringing this in is because if it was significant enough where you had IBD and you formed a PE, how good are the platelets? Is the integrity well preserved? ITP can be found a lot of times, idiopathic thrombocytopenia purpura, through IBD issues. So I see this because could the cavity have some level of blood filling? Could it just be, your own Xarelto, you're leaking blood from, other ends and so forth. So that's where I was thinking of, could that be more a hematologic process happening there than anything else? When I was asking about the findings about the adiposity buildup and so forth, is because again, if we talked about high, here's high level of steroids, you're immunosuppressed. Great. Steroids can cause other things, right? So usually if you're going to cause steroid-induced hyperglycemia, that's going to be significant enough to say rattle someone's glucose status and their A1Cs, you're going to see a strong association with Cushing-Wood-like factors, right? So it's hard for me to make an argument that someone's high-dose steroids are going to be impacting hyperglycemia to the level that you're forming diabetes complications without Cushing-Wood findings. So if you have Cushing-Wood findings, hyperglycemia suddenly rises to the level of potentially that's how our body state's been living in, then I'm looking for much more unique opportunistic infections that molds and other fungi can take advantage of. So that's what I was trying to go through that, right? You have immunosuppression that we talk about from just an immune standpoint. You've mitigated it with the steroids and infliximab. But there is, I think we all acknowledge diabetes has its own unique level of immunosuppression, but it's very different. The impairment, a lot of it has to do with the endothelial impact of elevated glucose levels. It impacts a correlate called a zeta potential. It just means there's more factors found in the blood that can impair endothelial integrity. And that just sets you up for very unique infections compared to, say, immunocompromised for steroids, immunocompromised from hyperglycemia. So it will just help me from a differential. So that's what I was trying to elucidate. But doesn't sound like she has that. Sounds like from my standpoint, she got some rounds of infliximab and steroids. So I'm thinking, you know, a brevity of it and letting loose whatever's in the nodule potentially still could happen. That fixated on that, though, with room to deviate. The fact that there's no PTKI telangiectasias and no purpura, no other dermatological findings, I think, you know, gives me an impression that the platelets integrity may be preserved regardless of the quantity of them. So, you know, I'm peeling back a little bit, I was hoping certain aspects of it will grab my attention so I can dive a little bit more confidently into one of the differentials, but alas, Max, that has not happened.
All right. Well, why don't I take us into labs here then? Because I think I'll give you some things to think about, some things to chew on here. So her basic blood count, she had a slightly elevated white blood cell count at 12. Her hemoglobin was slightly decreased at 9, and her platelets were within normal range at 500. Her absolute neutrophil count was 6.9, and her absolute eosinophil count was 1.0, 1,000, which is elevated. Her metabolic panel was normal, as were her liver function tests. Coags, I think I didn't write this down, but I think her PTT was slightly elevated, but not significantly. Her serologic workup became quite large, and I'll just, rather than make you ask for everything you want, I'll give you the things that were that are provided. She had an ANA that was negative. She had a quantiferon gold that was indeterminate. And looking back, actually, we managed to find an indeterminate quantiferon gold from prior to her initial infliximab treatment. She had a double-stranded DNA that was negative. She had C3 that was slightly low, and a C4 that was with normal limits. She had an ANCA panel done. An ANCA panel was negative, well, the ANCA itself was indeterminate, but the PR3 was positive reasonably strongly, and it was repeated and also still remained strong. In addition, a urine histoantigen was sent, and this was indeterminate, and a serum antigen was negative. She had a serum cryptoantigen as well that was negative, a serum toxo antigen that was negative, or sorry, PCR. And a bronchoscopy was performed at this time that showed 67% lymphocytes, no eosinophils, and was negative in its cultures, regular AFB and fungal. Aspergillus antigen was negative, as was PCP. Cytology was within normal limits, and a tuberculous gene expert probe was negative as well.
Okay.
There's a lot of information there.
Vivek, anything that these labs helped you like narrow your differential or expand your differential, or kind of what are your thoughts based on that?
So for the hemoglobin, do you know if it was you know, microcytic hypochromic type anemia?
You know, you got me on that one. I did not write that down. I believe it was slightly microcytic.
Okay. Okay. No worries.
Excellent question, though.
And apart from that, so the absolute neutrophil count was 6.9. Do we have the differential like percentage neutrophils and lymphocytes for the WBC?
I don't have it written down. I'm sorry.
Okay.
But it was
okay.
at this time it was close to normal, slightly elevated.
Okay. All right. So again, going by the, you know, by all of the bronchoscopic testing and the culture testing, I'm not seeing anything apart from the ANCA PR3 positive finding. You know, everything else is either negative or indeterminate. So the fact that her her bronchoscopy, you know, was negative for pretty much everything that was tested. That makes me think that maybe we're now looking at an autoimmune process or inflammatory process as opposed to infectious, especially given the lymphocytic predominance. And then that paired with the PR3 positive finding, but I don't quite know what conditions a positive PR3 finding would point us towards. So if you know, Panagis, if you could maybe help me on that a little, that would be great.
So a couple of things. I know we keep hitting on infection for potentially this cavitary lesion, but it should be pointed out, you know, like what are we thinking when we say infection? Like this is, I don't think this is a staph or a strep infection or a Klebsiella. These patients are much sicker, right? Even if you're immunocompromised to some extent, you're still sick. Like you're not doing well. Like, you know, the fact that she was bronchhed, everyone must have felt that she could tolerate a wet bowel, go in and out. So if it is an infection, it's going to be an atypical infectious process there. One that, you know, you can think of your mycobacterial, like your avium complex as your max to be present. So histoplasmosis is still on the table. Like these don't make people deathly ill, even though they are highly concerning on imaging. So from if it's an infectious process, that's what's coming to mind in my mind. The reason why I bring it up is, and you can correct me if I'm wrong, like it sounds like everything's been happening, like meaning if you bronch her, if this is a recent case, there's, you know, a lot of this data wouldn't have turned out immediately, wouldn't have, you know, still be cooking if this is a case you're still presenting within this time frame that I'm thinking of. I could be wrong, but a lot of these things take a while to come back, you know. So your BALs, the fact that it's highly lymphocytic and no eosinophils are present in there, to me still somewhat screams potentially an atypical infectious process. Autoimmune is there, that's fine. You didn't tell me if they sent cytology, because that usually they give you some understanding a little bit of the integrity of the cells that you find. But you know, I don't think this is a raging massive staph or strep. And not that I'm going to put my money down, I'm still highly suspicious of a potential concern around things like, what am I thinking of? Like an atypical infection. I say this because, I mean, she was put on infliximab and high dose steroids, which are still good treatments for a lot of autoimmune processes, even if they don't get to them specifically. I mean, your high dose steroids usually will not get anything. So if it was an autoimmune process, it'd just be odd that it blossomed through that, unless, you know, the fact that she had eosinophils in her blood means she's probably been off her steroids for a while. So unless this is a rebound effect that she's feeling that's come on. So that's how I'm still thinking like a very atypical bug, you know, one that's kind of has an insidious process to it, could potentially still be at play. Autoimmune is just, it'd be fascinating because, again, like I said, like she must have blossomed this in a time that she broke through good autoimmune treatments in order to develop it. Not that it's unheard of, it'd just be really odd and quick to develop.
Through kind of how you interpret quantiferin gold test and what an indeterminate test means, as well as kind of how you would put the PR3 in the context of knowing that there's inflammatory bowel disease.
Yeah, so I don't know what to make of the indeterminate quantiferin. I mean, also like the nodule's not in the place where I'd be suspecting TB to have occurred to begin with in the lower lobe. You know, if you're going to put TB down there, it's not going to really stay latent because of all the blood vessels that exist in the lungs. It's going to find its way out. That's why in the upper lobes, we find it to be latent in there because there's not that much blood circulation. So it could just kind of hibernate there and do just fine. So it's hard for me to know what to make of it. I mean, it'd be a really, could occur, of course. It'd just be really unusual for it to kind of blossom out of the lower lobe and cavitate in that fashion in someone who is, you're presenting otherwise is immunocompetent other than our iatrogenic interventions, unless, you know, you were going to reveal her HIV status and she's full-blown AIDS because of, and, you know, her eosinophilia is just kind of a deviation. Fine, you can maybe convince me of that.
Always a good question, but I'll just interject. She was HIV negative.
Thank you. I don't know what to make of the PR3. Again, you know, having that be positive, like like a rheumatologist said to me countless times, you can have as many biomarkers positive as you want. Their clinical relevance just depends on what they're exhibiting. She's developed IBD pretty recently this year, and you're kind of expediting a lot of, within a course of a year, she's got IBD and a pulmonary nodule that's blossomed. These are things that tend to take decades to develop in people with IBD. So, to be in this kind of expedited fashion and being on good interventions to suppress the IBD just makes me think not something else is going on, like something is happening that, the confounder to me is the autoimmune suppression that will either give way to an atypical infection or you just didn't treat the right autoimmune process. Like this is enough to knock out GPA. So that's why I'm hesitant to know what to make of those findings. Because you're put her on before I even touch a patient with GPA with say your rituximabs, to really knock out the B cells, I'm blasting them with steroids, right? Their nodules melt away and they wouldn't rebound so quickly to make me think GPA. With that said, I'm giving you my usual course of how I find things. So if you're gonna rock my world, I'm all ears, man.
Well, I'm glad to hear that you were as concerned about this as we were, because there was a lot of hand wringing and discussion. So I'll go on here to the imaging before the final aliquot of the answer. So during this time, as you've correctly assessed, this was a little bit of time in the hospital. We are not quite as efficient enough to get this all done day one. One day, maybe we will be. But during this time in the hospital, the GI team had seen her, decided that this seemed pretty reasonable for further flaring of her IBD. She was having lots of bloody diarrhea. Let's start the steroids up and get things going for her. So she starts out on a reasonable dose of prednisone after this initial set of labs in here. And her diarrhea actually dries up quite a bit. She's feeling a lot better from an abdominal perspective. However, during this time, a repeat CT scan is done to better evaluate these nodules and really focus in a little bit more on what we're seeing. The CT chest reveals that not only is the cavitary lesion now larger, and we're talking about 2 centimeters, we're not talking 5 to 10 centimeters. Not only is the cavity larger, but additionally, the lymphadenopathy that was noted but not commented on extensively in the prior CT scan from her PE diagnosis has now doubled in size. And better attention to it has shown that there's actually a calcified nature. So this left lower lobe is now twice as big as it was back in her initial diagnosis, is cavitary, and is growing despite now about a week and a half of steroids going on. The lymphadenopathy is enlarged on the left side, and this was concerning enough to all people involved, especially as further immunosuppression was concerned, to lead to a bronchoscopy with endobronchial ultrasound and fine needle aspiration. And so coming in, again on the left side here, station 7, right at the carina, there was no evidence of malignancy, no granulomas and heterogeneous lymphoid cells consistent with normal lymph node. And then furthermore, on the left lymph node closest to the hilum, 11L, similar. There was some necrosis with rare granulomas, but it wasn't 100% of a diagnosis. Again, no malignancy, no acid-fast bacilli, and no fungal organisms by GMS stain. So there is one final test, which will reveal the final diagnosis. So at this point, I'll leave it to you guys.
Max, do you have the CT scan that you could share an image of available?
I can. If you guys want to share your thoughts while I pull that up, let's see if I can pull it up, because it was quite colorful here. Or I thought it was colorful. If you like CT scans.
Vivek, do you have any thoughts on that?
Mm-hmm. Yeah, so the CT scan is super interesting, I'd say. Just the fact that she's got an increased size cavitary lesion, got lymph node involvement now, but with no evidence of malignancy. I'm probably thinking more along the lines now of like an atypical fungal organism or I know AFB was negative, but I'd probably still keep TB somewhere on the table. Apart from that, malignancy, unless it was missed, they just didn't get the right sample to prove the malignancy when they did the fine needle aspiration, but there is necrosis of some of the lymph nodes. So the granulomas kind of, again, make me think of, acid-fast bacilli or possibly some sort of granulomatous process. But yeah, I mean, the only other thing I can think of doing with some of that sample is maybe I don't know, doing like a KOH test to look for fungal growth. That's the only other thing I can think of right now, but I might be way off on that. So
Vivek, I like the way you're thinking, man. Hopefully you'll be a lung doctor one day. I mean, everyone should be a lung doctor one day.
I hope so. Do like that a lot. So.
Anything else, Vivek? Oh, go ahead.
That's pretty much what I can think of at this point. I'm a little stumped right now, to be honest.
Yeah.
Daddy, can we close the first and go to Amy's?
All right, bigyan na ba sa Lucas o Giffartado?
But I don't see them.
Okay, kasi the brown go. Sorry, I got my 3-year-old is interrupting. She's trying to. Oh, do you want to say hi to everyone? Okay.
I want you to.
All right. Here, I'm gonna lift you up. Ready? You want to say hi?
No.
No. Okay, then I'll put you back down. Okay. And then lift up. All right, let me just grab her something, and I'll be right. This will take 2 seconds. But I agree, Vivek. I agree with your thoughts. I mean, the fact that she's got some rare granulomas is massively important to recognize. So more to come. Let me attend to her. I'll be right back. Max, the floor is yours.
Well, I'm very sorry here. My imaging software is not enabling me to pull it up here. But if you can imagine a 2-centimeter cavity down here and a big old lymph node up here, it was really excellent. It really sparked joy. Let's see here. Emery, you want me to stall for just a second here?
I'm back. Sorry.
Oh, you're back.
Yeah, so I gave her a princess outfit. She's getting dressed as we speak. So again, I still, from my standpoint, she had a pulmonary nodule to begin with. So all of this, all of this was in the background. She was given steroids and infliximab, and suddenly the nodule kept getting worse. From my standpoint, I think a good atypical infection can cause that in the right setting. I mean, yeah, I know we can sit back on TB, but there's TB cousins, like other mycobacteria that can cause this. And, I'm thinking of infections that aren't lethal in immediate sense, like you think of like a Klebsiella or Staph aureus. I'm thinking of ones that are more insidious that kind of rob you over time. So that's where my head is going at the moment. Histoplasmosis could of course still do this and so forth. And you got some rare granulomas that, from my standpoint, kind of rules out sarcoid because it's much more well organized, though it can cause these cavitary lesions. Could your GPA be on there? Sure, your vasculitides, but again, like my challenge with that is you're on good treatment for it. Why would it break through? So I'm still going to hang my hat to some extent on potentially an atypical infection. That's where a lot of my mind is going. But I will say the chest CT, if I was doing this in real time, that's where I would have gone to first to kind of tell me one way or another. So sorry about that.
Yeah, and my apologies too for not having that prepared ahead of time here.
Oh, Max, you're fine, my friend. You have a very colorful presentation of it. So
I love CT scans, so I'm very ashamed.
I mean, you got the biopsies done, you send them off. I mean, if it's a mycobacterial thing, even with an AFB being negative, it's going to take time really cook. I mean, and then you really have to discuss, like, do you treat it or not? Histoplasmosis, by the way, did you send off both blood and urine?
So again, urine antigen came back indeterminate. A repeat, because there was a lot of concern, was also indeterminate. A serum antigen was negative.
Got it. Okay. It's pretty reasonable to say you slew through that. All right.
Well, I hope you feel the tension we had at this moment of, do we push the immunosuppression, or do we push the treatment? What do we treat here? Because this really gripped us for several days here. Am I okay to go ahead and give you the last aliquot here for the answer?
Max, I just had a quick question before you do. Did you send off like Fungitel or the beta-D-glucan, the other name for it, or kind of that test? I was just out of curiosity's sake.
I don't think that we ended up sending a Fungitel out, though. That's a really good idea. I don't know. There was some internal politics about the utility of Fungitel, but in the end, no, one was not sent.
All right, we're at the edge of our seat, man.
Big reveal.
The big reveal. So as these things are, they take a while to come back. And she was actually she had already actually left the hospital doing much, much better from a diarrhea perspective, but still, kind of getting a little bit better from a pulmonary perspective. And at this time, we thought this was a little more consistent with potential necrobiotic nodule with her IBD. However, just to prove us wrong, a couple days after she left, her antihistoplasma IgG came back at 77.5 with a low positive between 8 and 10, and 10 and above being strong positive, which convinced us that this was an old histoplasma infection that had been reactivated under the presence of infliximab. We started her on itraconazole, and she's had significant improvement on CT imaging repeated. Her chest pain is resolved, and frankly, it's hard to get her out from her home to come visit the hospital because she's doing so well. Her GI team has started her on on infliximab and has gotten support through the university to get her that in a more affordable fashion, and she's been very well controlled from that perspective too. We were very anxious over getting that started before we had the formal diagnosis, but fortunately they came about the same time with each other, and she's had good results moving forward here. I think the thing that we learned about when we were looking through this is that infliximab, you think about the anti-TNF properties predisposing to reactivation of tuberculosis. But it can also occur with other chronic granulomatous disease, other granulomatous diseases that can sometimes remain a little bit dormant. And I hadn't heard of this in histoplasma before, but it works by a similar method. The thought of a necrobiotic nodule similar to rheumatology had also been documented in the literature. And that was actually what we were hanging our hat on initially, but it's a good reminder that the histourine antigen is specific, but is not terribly sensitive. So you can miss a diagnosis, and a high antibody titer can help confirm things. So, and the last thing that we learned along with this, well, first that a gene expert can be put on a bronchoscopy, which can be a very, very sensitive probe for tuberculosis, because we were thinking this was slam dunk tuberculosis. But that PR3 ANCA positivity is actually associated with IBD and is technically more strongly associated with ulcerative colitis, though it's not a great diagnostic test for distinguishing between them. And ultimately, the GI team centered in on Crohn's disease with more colonic involvement as her primary GI diagnosis. So excellent work, you guys. I think both of you called this out early on. We're watching it, and I hope you were equally confused along the way as the test trickled back, because this was a big challenge for all of us. But I'll answer any other questions if you have them here.
Oh, that was a great case. Well done, Max. Well done. And Vivek, nicely done, buddy. I owe you a coffee.
Vivek, nice job. Pulmonology for days.
Thanks. Thanks, Max. Great case here.
Can I ask you, kind of in having the retroscope here, did calcification of the lymph node, you know, kind of that's something I associate with histo, would that change as well as TB? Would that change your differential at all? Like kind of in real life, would that play into your differential, or is that something that is kind of more like a buzzword?
No, it would. So also splenic calcifications are so Max, I know you're a few years away from pulmonary boards, but gosh darn it, man, do they love hammering home splenic calcifications. They're like, all right, moving on. So the calcification, it's just that, so is it a buzzword? It is a buzzword oftentimes, but you can find, let me take a step back. You can find calcifications around granulomas, right? It just, to some extent, it just tells you more of chronicity, like, oh, this is really old. Doesn't tell me, Sliam dunk histo. The splenic calcifications would have given me more, like if that was ever said, but calcifications when a lymph node biopsy, I mean, it plays well to teach it to med students, but at the end of the day, it really just speaks to chronicity. Like sarcoid can still give you that. Like it just, it's been there for some time is all it's telling me. So when I heard that, I was like, I'm going to refrain from calling it out because I've been burned so many times. The only times I ever get calcifications right on lymph nodes is on UWorld, never in real life. So that's what I would say.
Awesome. Well, thank you so much, Max, Vivek, and Panagis. Such an awesome learning session. Any final thoughts before we go to teaching points with Rafa?
I would, my quick closing thoughts is I know Max was doing this well, but it is definitely look at the patient, right? Because if you see, you hear cavitary lesion, but Max is telling you like, she's fine, room air, a little bit of chest pain, we're going to bronch her. This tells me it's someone who's handling it, right? She's doing well, right? So right off the bat, I'm removing, this can't be a staph, this can't be Klebsiella. You know what I mean? Like those are lethal. That patient is dying. She's doing great. So if you're thinking of infections, I think this is what I always try to teach. Like you got to think of what the patient's presenting with. If they're doing fine, even asking to go home, you got to think of more insidious bugs. So your fungal, your atypical bacteria, that's what comes to light here. And I think that's important to recognize because your patient, with all this other data, how your patient looks is really, from my standpoint, the biggest physical exam finding. If you're telling me they're calm, cool, collected, I'm thinking of something else. So that's my big takeaway. That's why I was stuck on infection, but I was stuck on and I should have said that earlier, I was stuck on much more insidious bugs, like your histos, your mycobacteria and so forth. So Max, well done with really actually providing that, even if that wasn't like a main focus, but you really did paint that well.
Well, thank you very much.
Awesome. Rafa, do you want to take it away with teaching points?
Yeah, so just to begin with, I just want to thank Panagis for accepting the invitation, Max for preparing the case, and Vivek to discussing with us. It was such an awesome learning case for us. And so we had a patient with dyspnea and chest pain in the setting of IBG. And when it comes to dyspnea, we actually have to think about cardiopulmonary processes, but we have to remember other causes as well, for example, anemia. And then we saw that this patient had infliximab and steroids, and those drugs can put the patients in immunosuppressed states with increased risk of infection, especially fungal, like TB and histo, which was the case, mycobacterial infections like TB, but also sarcoidosis. And then Panagis reminded us that the respiratory tract and the GI tract actually have a common embryonic origin, which is the endoderm. So there are many extra intestinal manifestations when it comes to IBG and also in the respiratory tract. For example, it can lead to nodules, colorectal fistula, bronchiectasis, pulmonary function test abnormalities, and thromboembolic disorders. And then when it comes to cavitary lung lesions, we can divide that based on infectious causes, malignancy, autoimmune, and other causes as well. Infections, it could be acute, for example, necrotising in the setting of staph, but also septic emboli, for example, Lymph, or subacute, for example, mycobacteria or fungal infection, and even parasites. When it comes to malignancy, we have to remember squamous cell carcinoma, but also metastasis, for example, coming from the GI, the GU, but also lymphoma. And then autoimmune causes like GPA, RA, other causes as well, like PE in the set of infarct. And then we saw that this patient had a lymphocytic predominant BAL, and we have to remember about atypical infections, especially because this patient had like this insidious common presentation, sorry. And then we have to remember also pulmonary sarcoidosis, hypersensitivity pneumonitis, HIV-associated pneumonitis, but this patient was HIV negative, but also drug-induced, like sirolimus. And then finally, we saw that this patient had granulomas on the pathology, and we thought about TB, MAC, lymphoma, sarcoidosis, GPA, and histo, which was the case. So thank you, everyone. I hope everyone enjoyed this case. I did and learned a lot, and I hope to see everyone tomorrow on Neuro VMR.
Awesome. Have a good night, everyone. Thanks again to Max, Vivek, and Panagis. We really appreciate it.
Thank you, everyone.